All right, talking about cardiac output. Cardiac output is one way to measure cardiac function. There are a lot of different ways to measure it, but we're going to talk about cardiac output to start with. There's another measure that we're going to talk about that's called ejection fraction, and it's the amount of blood. So you have a certain amount of blood in your ventricles, how much of it gets ejected each time your heart beats. And that's a measure of cardiac efficiency. So if your cardiac efficiency falls off enough and you're only ejecting, 20% of it, barely shooting out any blood every time, that is considered heart failure. So we'll talk way more about that. But your heart rate is basically the number of ventricular contractions per minute. So the normal range is about 65 to 80. And that's our pulse. When we talk about our pulse, that's our heart rate, number of ventricular contractions per minute. So anything less than 65 is considered bradycardia. Anything higher than 80 is considered tachycardia. So bradycardia can be caused by lots of different things that we'll talk about. One of the things it can be caused by is just good health, efficiency. A long, long time ago, when I was in an EMT training, and there was a guy in there who was a cross-country ski racer. So as you can imagine, his heart was pretty darned efficient. And he had a resting heart rate of about 45, because his heart was so efficient pushing that blood out there. It didn't need to beat very fast in order to keep his oxygen levels up. Because here he was cross-country skiing at high altitude every single day. And he probably had all sorts of red blood cells working that oxygen for him. So because his heart rate, his resting heart rate was so low, it was very difficult to take his blood pressure because his heart was beating slowly and you had to let the pressure out of the cuffs slowly enough to get a reading. So bradycardia can be caused by good health. They can be caused by other things too. But and tachycardia, if you're exercising, your heart rate's going to be higher. And we'll talk about that in a little bit. So cardiac output is the amount of blood ejected by the left ventricle in 1 minute. So if your heart is beating 65 beats per minute and it's ejecting a certain amount per beat, then that gives us our cardiac output. So the normal output is about 5 liters per minute. You can be 4 to 5 times that when you're exercising, because there's that much more demand on your body. And the normal output volume of each stroke, and by normal we mean average, is about 70 milliliters. So basically the formula for cardiac output is stroke volume times heart rate. And that makes sense, right? Because cardiac output is the amount per minute. So liters per minute or milliliters per minute, however you want to express it. And so it's your stroke volume, which is your milliliters, and your heart rate, which is number of beats per minute. So stroke volume is the volume of blood pumped out of the ventricle with each contraction. So 70 milliliters, 70 milliliters, 70 milliliters every time your heart beats. And the heart rate is your heart rate, how many times per minute your heart's beating. The preload is the amount of blood delivered to the heart by the venous return. So basically, when your heart is preloaded, that is when you're at the end of diastole and the chambers are full of blood and they're ready to push it out on the next stroke. Afterload is the force required to eject blood from the ventricles, and it's determined by peripheral resistance in the arteries. So remember how we said how the arteries are pretty elastic and pretty strong, because they have to meet that pressure of the blood being ejected from the ventricles. So they have to be able to go, oh, there's my 70 milliliters. Oh, there's another 70 milliliters. Oh, there's another 70 milliliters. So the arteries have to each time your heart beats, the arteries take a little bit of pressure. And so if you have higher blood pressure, there's going to be more afterload, and it's going to put more work on your heart. Hopefully that makes sense. So to increase cardiac output, we have to increase stroke volume or increase heart rate, or do both, or increase preload, increasing venous return, or decrease afterload. So there are all sorts of things to do. So if you say, okay, my heart's not working very efficiently, what can I do to increase my cardiac output? Sometimes the answer is to decrease the afterload by decreasing your blood pressure. And so a lot of the cardiac medications do that. So think about that as we're talking about things. Think about what are the changes that we're making and how are they affecting cardiac output? So increasing stroke volume, that you do by making your heart stronger or by increasing preload. Increasing the heart rate, it's all those different things we said that could increase heart rate, sympathetic response. Some of it is medication driven if you're treating a disorder, or both. And decreasing the afterload so you get a better stroke volume. So you get less resistance to your stroke volume. So we'll talk a little bit more about preload and afterload. So preload is also known as the left ventricular end diastolic pressure, LVEDP. So it's the amount of ventricular stretch at the end of diastole. So you can think of it as the heart loading up for the next big squeeze of the ventricles during systole. So we're stretching. Remember in kinesiology how we talked about you do that, a little bit of a stretch, and then you get a big muscle contraction. Works with the heart muscles too. So the amount of blood in the ventricle at the end of diastole is the preload, and it's also the muscle length prior to contractility. It's dependent on ventricular filling or end diastolic volume. And this value is related to right atrial pressure. So the most determining factor for preload is venous return. So remember how we talked about lymph disorders, and if the lymph is being trapped in peripheral areas of the body, you're not getting it returned back to the venous system, and so we're decreasing our preload, so it affects your heart efficiency. It's all connected. It's all connected, which is amazing. It's amazing how it worked. So that's preload, and so if you increase your preload, you can increase your cardiac output by increasing your end diastolic volume, and then you get that nice pre-stretch, big contraction, boom, out goes the blood. The afterload is the tension or the arterial pressure against which the ventricle has to contract to shoot the blood out there. If arterial pressure increases, afterload increases. And if afterload increases, stroke volume decreases, and cardiac output decreases. So afterload for the force of the left ventricle has to generate during systole to overcome the aortic pressure and open the aortic valve. So aortic pressure is keeping the valve closed, and the left ventricle has to overcome that to open the valve and get the blood out of the heart. So afterload for the right ventricle is determined by pulmonary artery pressure. That makes sense, right? So afterload reflects pressure or resistance in the peripheral system against which the heart must work. It's also known as systemic vascular resistance. It's the amount of resistance the heart has to overcome to open the aortic valve and push the blood volume out into the systemic circulation. So if the pressures are equal and the valves are closed, nothing's happening. You have to overcome that vascular resistance or arterial pressure to open the valves and get the blood out of the heart. So the preload and the degree of contractility are directly proportional to stroke volume. So bigger preload, bigger contractility, bigger stroke volume. Afterload is inversely proportional to stroke volume. So higher afterload, lower stroke volume. So hopefully that makes sense. Think about that in your head. We'll keep talking about it and keep trying to figure it out and reinforce it. And then its implications in disease. That's That's the fun part. Well, you know, fun. So the end diastolic volume is the volume of the blood in the ventricle just prior to contraction. It's the amount of ventricular stretch at the end of diastole. You can think of it as the heart loading up for the next big squeeze of the ventricles during systole. So that's that pre-stretch on the muscle that's going to give it the big contraction. Okay. The end systolic volume is the volume of blood in the ventricle at the end of the contraction. So end diastolic volume is at the beginning of the contraction, and systolic volume is at the end of the contraction. The difference between those two is our ejection fraction, the proportion, okay? The stroke volume is the volume of blood that's pumped from one ventricle with each beat. So the stroke volume is the end diastolic volume minus the end systolic volume. So it's the amount of blood you start with minus the amount of blood you end up with, and that's what goes out of the heart. So hopefully that makes sense. That's the amount of blood going out of the heart. I'm trying to describe it a lot of different ways so it kind of makes sense, hopefully. So here it is again. Cardiac output is the amount of blood pumped by each ventricle in 1 minute. So we're averaging about 5 liters a minute, or 4,900 to 5,000 milliliters per minute. The heart rate is the number of contractions of the ventricles of each minute. And so the stroke volume is the amount of blood ejected from each ventricle with each contraction. So the factors that affect cardiac output: sympathetic nervous system stimulation, so epinephrine, that's going to stimulate that heart rate. So increasing the heart rate increases cardiac output. Increased preload or increased venous return increases the stroke volume, and that increases cardiac output. Sympathetic nervous system for muscle contractility, that increases cardiac output, and decreasing peripheral resistance, the afterload, that increases stroke volume and it increases cardiac output. So when you think about the learning objective of what things increase cardiac output, that's what it is: increased heart rate, increased stroke volume, and what affects heart rate and stroke volume. So the blood pressure, the systolic pressure is exerted upon the cardiovascular system when blood is ejected from the ventricles. That's the high number. The diastolic pressure is the sustained pressure when the ventricles relax. That's the lower number. So it's never zero. That's bad if it's zero. Then you're probably not alive if it's zero. Blood pressure is altered by cardiac output, blood volume, and peripheral resistance to blood flow. If you have increased cardiac output, you're going to have increased blood pressure. So as a response to exercise, we have increased cardiac output, we have increased systolic blood pressure. We're going to practice that, you know, exercise, measure blood pressure, etc. If you have increased blood volume, you'll have increased blood pressure. If you have decreased blood volume, you'll have decreased blood pressure. If you have increased peripheral resistance, you'll have increased blood pressure. If you have decreased peripheral resistance, you have decreased blood pressure. So get those relationships in your head. Blood pressure is changed again by the sympathetic nervous system. So it's the sympathetic branch of the autonomic nervous system. Increased cardiac output, you get vasoconstriction and increased blood, or increased sympathetic output, excuse me. You get vasoconstriction and increased blood pressure. Decreased sympathetic output, you get vasodilation and decreased blood pressure. So blood pressure is directly proportional to blood volume. Higher blood volume, higher blood pressure. Lower blood volume, lower blood pressure. Okay, so the hormones that affect blood pressure, antidiuretic hormone is one of them. It prevents you from losing fluid. Diuresis is the loss of fluid. Antidiuresis keeps fluid, so you have higher blood volume, higher blood pressure. Aldosterone increases blood volume, increases blood pressure. The renin-angiotensin-aldosterone cycle that we talked about a little bit last quarter increases vasoconstriction, so it increases blood pressure. So think about those relationships. So just like a lot of things in the heart, it's either hormonal effects or sympathetic nervous system effects that are affecting heart function, cardiac output, and blood pressure. So during and after exercise, so the systolic pressure is when the blood is ejected from the ventricles. That's the high number in your blood pressure. The diastolic pressure is the sustained pressure when ventricles relax. That's our lower number. Blood pressure is altered by cardiac output, blood volume, and peripheral resistance to blood flow. So during exercise, cardiac output increases, so systolic pressure increases, and the diastolic stays relatively the same. So the difference between systolic pressure and diastolic pressure is called pulse pressure. So if the diastolic stays the same and the systolic goes up, that's an increased pulse pressure. If this diastolic goes up and the systolic goes up, you don't have increased blood pressure or pulse pressure. After exercise, the systolic pressure should decrease back to normal. So the normal response to exercise is you increase your cardiac output, your systolic blood pressure goes up, and your diastolic stays relatively the same. So if I gave you a question, and I believe there is one or maybe more than one on the practice quizzes, if I said you are having this person exercise in physical therapy, here's their blood pressure at the start, what do you expect their diastolic to be after 5 minutes? You would be able to tell me, I hope. If the systolic doesn't go up, that's an abnormal response to exercise. If the diastolic does go up, that's an abnormal response to exercise. So what we want to have is the diastolic stays relatively the same and the systolic goes up. And the systolic goes up at the same rate as VO2, the volume of oxygen in your system, because we're getting an increased cardiac output. So when you hit VO2 max, your systolic blood pressure levels out and it stays at that level until you stop exercising and your cardiac output decreases, and then your systolic pressure goes back down as a normal response. So when we are working with patients in the clinic, we want to check that they are having the normal response to exercise. That's very important.